Hi, I'm Dr. Aditi Goimawala-Garg, a pediatric neurologist. Every week on this channel, I translate the brain science behind the conditions that change children's lives, for the doctors treating them and the families living with them. Let's get started. A child wakes up and cannot move their arms, or they have a seizure out of nowhere. Most people's first thought isn't stroke, but it should be. Stroke in children is real. It's underdiagnosed, and the window to act is narrow. Today, we are breaking down everything you need to know about pediatric arterial ischemic stroke, from how it presents to why it's missed and how we treat it. Let's get into it. What is pediatric arterial ischemic stroke? Arterial ischemic stroke, or AIS, is a focal infarction caused by occlusion of a cerebral artery. Blood reaches the brain through two main systems: the anterior circulation via the internal carotid arteries and the posterior circulation via the vertebrobasilar system, both converging into the circle of Willis. The middle cerebral artery is the most commonly affected territory, but stroke can occur in any cerebral artery of any size. So why it is missed so often? Here's the problem. Diagnosis is frequently delayed, and there are 4 reasons to that. 1. The presentations can be subtle and non-specific. 2. The primary care awareness is low. 3. The differential for hemiparesis is wide. And 4. More than 50% of initial CT scans are negative for true AIS. The last point is critical. A normal CT does not rule out stroke in a child. The rule to remember is acute onset of a focal neurological deficit in a child is stroke until proven otherwise. So how does it present? The most common presentation is hemiparesis, but you'll also see acute visual deficits, speech disturbance, sensory loss, and balance problems. In infants and younger children, pay close attention here. New onset seizures, especially focal motor seizures, can be the first and only sign of stroke. Any child with these presentations need urgent neuroimaging and a pediatric neurology consult. Emergency intervention may be on the table. So how do we diagnose stroke? Acute arterial ischemic stroke is both a clinical and radiographic diagnosis. CT scans show mature infarcts and rule out hemorrhage, but cerebral MRI is required to catch early and small infarcts. Diffusion-weighted MRI is your go-to. It picks up AIS from minutes to 7 days after onset. MR angiography can then confirm vascular occlusion and point towards an underlying arteriopathy. One more thing DWI can show is the Wallieren degeneration in the descending corticospinal tracts, which correlate with chronic hemiparesis down the line. Now let's come to the etiology. There are 3 main categories: arteriopathy, cardiac disease, and hematologic disease. Arteriopathy is the leading cause, present in over 50% of children with AIS. The classic pattern is focal cerebral arteriopathy, or FCA. Unilateral irregular stenosis of the proximal MCA and neighboring arteries, often with basal ganglia infarction, is monophasic and usually self-limited. FCA can be subclassified as inflammatory type, dissection type, or undetermined. Because at presentation it can be indistinguishable from intracranial dissection or early moya-moya. Arterial dissection, spontaneous or post-traumatic, more often involves extracranial arteries like the carotid and vertebral. Moya-moya is progressive occlusion of the distal internal carotid arteries. It can be idiopathic, that is moya-moya disease, or associated with sickle cell anemia, NF1, trisomy 21, Williams syndrome, Argyll syndrome, and post-irradiation states. The cardiac causes account for about 25% of around childhood AIS. The highest risk is around interventional catheterization, surgical repair, or ventricular assisted device use. Complex congenital heart disease leads the list. Don't miss acquired causes like arrhythmia, cardiomyopathy, and infective endocarditis. A patent foramen ovale is also a conduit for paradoxical venous thromboembolism. Every child with suspected AIS needs a cardiovascular exam, an ECG, and an echocardiogram. Hematologic disorders. Sickle cell disease increases stroke risk by 400-fold. Transcranial Doppler screening and transfusion therapy have significantly reduced that incidence. Iron deficiency anemia is an often overlooked, easily treatable risk factor. Prothrombotic states like factor V lead-in, antiphospholipid antibodies, elevated lipoprotein A also feature here. These are some of the genetic associations with thrombotic, hemorrhagic or vascular stroke. Genetic arteriopathies are an expanding category. ACTA2, COL4A1 and ADA2 gene variants are associated with AIS. Targeted genetic testing and whole exome sequencing are now recommended in appropriate cases. So how do we treat stroke? Treatment is multifaceted. Let's go through it systematically. So we start with hyperacute neuroprotection. It starts within minutes. Control glucose. Avoid both hypo and hyperglycemia. Control temperature. Avoid hyperthermia. Maintain cerebral perfusion. Avoid hypo and hypertension. Maintain oxygenation. These are not optional steps. Seizure management is both urgent and neuroprotective. Consider continuous EEG monitoring in the acute phase. Thrombolysis and thrombectomy. The evidence based in children is mostly anecdotal. Some pediatric stroke centers offer both. In adults, thrombolysis within 4.5 hours and thrombectomy up to 16 to 24 hours improve functional outcomes. In children, especially those under 5 with comorbidities like congenital heart disease, thrombectomy should currently be approached with caution pending more data. Antithrombotic therapy. Early initiation is critical to prevent reinfarction. Anticoagulation with heparin for cardioembolic causes, antiplatelet therapy, usually aspirin for arteriopathy. Disease-specific treatment includes transfusion in sickle cell disease, immunosuppression in vasculitis, and revascularization surgery, bypass or encephaloduroarteriosyngiosis in moyamoya. Watch for early malignant cerebral edema, more common in children than adults, life-threatening and predictable. Emergency surgical decompression can be life-saving. Now let's have a look at perinatal AIS. Perinatal stroke deserves its own mention because it presents completely differently. There are two presentations. The first is acute symptomatic neonatal AIS, focal seizures within 24 to 48 hours after birth. Cranial ultrasound frequently misses it. DWI MRI in an arterial territory confirms recent infarction. Second, the silent presentation. The neonate often appears normal at birth, then presents in later infancy with early hand preference or congenital hemiparesis. Hand dominance in the first year of life is always abnormal. Imaging shows focal encephalomalacia, typically porencephaly in the MCA territory. These are the risk factors for perinatal AIS. Causes include congenital heart disease, thrombotic placentopathy, and meningitis. Many cases remain idiopathic. Antithrombotic therapy is rarely needed in neonatal AIS. Recurrence risk is low, unless congenital heart disease, prothrombotic disorder, or arterial anomaly is present. Around 50% have normal or mild deficits, but 25% have significant long-term disabilities. Perinatal stroke accounts for the majority of hemiparetic cerebral palsy cases. So, what are the outcomes of stroke? Recurrent stroke can occur in 10 to 50% depending on cause and prevention strategy. Death occurs in 2 to 6%. Neurological deficit occurs in 60 to 70%, which is usually mild. Long-term seizure disorders occur in around 30%. Adolescents with cryptogenic AIS and a patent foramen oval percutaneous PFO closure should be considered for secondary prevention. Rehabilitation must be multimodal and family-centered, targeting motor, language, cognitive, behavioral, and epilepsy outcomes. Pediatric stroke is rare, but when you miss it, the cost is enormous. Know the presentations, scan early and with the right modality. Investigate the full triad of arteriopathy, cardiac and hematologic causes and act fast. If you found this useful, save it for your next case. The next video covers cerebral venous sinus thrombosis, the other stroke most people miss in children. See you there. Thank you. Bye.